Thanks, everyone, and good afternoon. It's a great pleasure to be here. Thanks for the invitation. Actually, that's what PCI is about. We have very international guys here. We have to share our mindsets. We have to improve our knowledge by sharing our ideas. And that's why I love to be an interventional cardiologist. So I will start giving you a couple of ideas from myself regarding tools for complex PCI, and then I will hand up over to you, and you will show us probably a complex CTO case. So we start with the more basic one, and then we jump over. So PCI is a thing you have to evolve. You start by doing a simple thing. A wire, a balloon is probably complex for you. You step up, then imaging is coming, complex things are coming, and the higher you get in this pyramid, the more complex tools you will need to achieve a good outcome for the patient. Once, probably all of you know Andreas Grünzig. Yes, no? Andreas Grünzig? He's a pioneer. He actually invented PCI 35 years ago, and he once said, when we can break the barrier doing CTO PCI, the surgeons are gone. So 35 years later, surgeons are still there, but we can achieve and do CTO PCI. And that's hopefully because we have good material on our shelf. I want to quickly go through a couple of slides regarding microcatheters, and then I will tell you a little bit my ideas about guide extension catheters. Why? Because I love them. So this here you can see probably a CTO-ish lesion of an artery. You have here an elongate place, a microcatheter, and you will probably try to bring a wire through that lesion. The wire is coming. You will choose your wire wisely to achieve it, to manage to torque it through that micro channel, and then you probably will engage your microcatheter through. So no wire is crossing, so you will not do microcatheter crossing, and you will end up not doing a PCI. And what purpose, after choosing the right wire as a microcatheter? It's a thing of guide wire support. It will increase your effective tip load. You facilitates the wire exchange and facilitates also retrograde options. When you take a microcatheter, you have to think about what you're going to achieve. So you have a micro task, you have properties, and this combination is leading to success. You have to understand what you want to achieve before you take your tools, for instance. Do you have a calcium monster ahead and you need something strong to talk your way through? Do I have a simple lesion which is a bit tortuous and you need a straightforward microcatheter or anything else, a channel dilators? There you come with the microcatheters from APT to the long family. Especially the taper tip one. I will introduce it to you because it's very flexible. It gives you a lot of support. When it's in the lesion, you can torque it either both sides, clockwise or counterclockwise. And you see there, it's a very maneuverable, flexible microcatheter, braided. It gives you, as I said, a lot of support, enhancing your complex PCI. This is a pretty much straightforward thing. You see a huge left main, maybe 7 or 7.5 millimeters, and a bit of a CTO-ish lesion, maybe a stage 1 CTO, if you want to call it like this. And the problem of this lesion is not the lesion itself, but the very huge left main, and you have to engage the proximal cap of this lesion. And what I did here, I put a wire, this was a Gladius wire I took, with a huge bend, because you need tip load to maneuver it, to engage the lesion. Then I took the elong, because of its flexible taper tip, it was easy to engage it to the proximal channel. I left it there, exchanged the wire, and the wire flew through the region. So it was an easy thing to do the job here. So that was the last slide from the point of view of microcatheters. You have always to ask yourself, what is the task? Choose the material wisely, and then you will have success. Now, the second thing.
So you think it is a good combination between the tapered and the gladius?
Why not?
No, I'm asking.
I think it is the thing that the question is probably what kind of lesion you have ahead. I choose the wire according to the lesion and not to the microcatheter. So I don't care if it's a polymer wire or a stiff wire. If you have if you want to have a good support like this, you have this tilted wire in the proximal cap. You can advance also stiff wire through. It doesn't matter in my opinion. So the second part of my talk, the guide extension catheters. I love them. Why? I want to tell you. We all know situations like this. This is a Stevie Wonder PCI. You see JR4 guide hanging around it, or the wire is down. Patient is probably a bit unstable. That's why you don't want to remove that wire, and you will not have any success probably, because you see the balloon is stuck in the proximal bit of this artery. So what shall we do? We have a couple of things. I want to tell you now how the old-fashioned way is to maneuver something down. So what can we do? We can improve support. Extra support wire, we can. But it's not so super nice to bring down a wire here when you have trouble anyway. You can change the guide. You don't want to do that. So no way. You could actually torque the catheter clockwise to engage it deeply into the vessel to improve the support. And obviously you can do it, it works. But you have some restrictions. You can destroy the artery, you can actually manipulate the proximal lesion, and then you have a kind of a daughter technique, which is not what you want to do nowadays. So it is working, but it's not so super sexy. Another thing is the body wire technique. I think everyone used it. You can also do a distal anchor technique, for instance. Is it working?
Yeah.
Okay. For me, it's not working. Bodies are good, but I prefer these bodies here. Now, again, a picture of Andreas Krunzig, a picture of the 70s. And probably he was asking himself, oh, how can I bring down those materials in this vessel? And in 2009, it was groundbreaking because the guide extension catheters, and I was amazed when I was preparing this talk because it's not so long. It's 16 years ago, and this is a groundbreaking thing which actually changed and affected the way how we work nowadays. We have a couple of them on the market, and the base of every guide extension catheter is always the same. You have a distal shaft with a stainless steel color. You have this introduction part in the middle of it, and the very distal shaft part, which is actually a bit differentiated between the different devices. But things changed over the last 10 or 15 years. You see the historical guide extension catheter here. And this thing actually, probably you know it, if you've used the primary version, probably destroyed a couple of stents, obviously, because the introducing part was made of metal, it was rough, and every time you want to engage something, probably you lose the stent, you destroy the stent, or it's simply not going in. You see here the expressman with this one piece design, which actually facilitates the introducing of the material. What is the purpose of guide extension? This is a patient I've done at 2 o'clock in the morning. It was awful because it was a 4.5 EVU and I was not even close to manage to get a picture done. And I blindly threw a wire somewhere, engaged a guide extension, and I was able to at least have a picture of it. So coronary engagement, then different animal, perforations. In situations like this, you want to be sure that your covered stent is going to the place of interest and not hanging approximately. Or different setting, patient got flow limiting rotor stuck. Who's ever seen this knows how uncomfortable you are in a situation like this. And as you can see, there is a wire beside the rotor ablation burr, and we try to dislocate it, but not successfully. What you actually can do in this situation, and I really like it, you cut the rotor wire close to the drive shaft at the black rubber part. You remove the sheet. You engage the guide extension catheter. Also put a lasso through it. I think you can pull, and in 95% of the cases, it should work to dislocate or disengage your rotor burr which was stuck. And last but not least, the CTO techniques, we'll probably see later on, are also a purpose of guide extensions. This is just for you, just a bit of a different view now from here that was done by myself during my fellowship in Northern Ireland with yoga. Now, how do we use guide extension catheters? I love to have two techniques. Everyone should be able to do two techniques. Maybe it's a repetition for you, but it is a nice thing anyway. So here, first technique, this length technique, you can call it however you like. I was actually doing a publication. There was a discussion going on. There was the wrong name, maybe. I'm not sure. Call it however you like to. But use a balloon, put it into the lesion, glue it up, push the guide extension catheter forward until it reaches the edge of the balloon, deflate it, and eventually the balloon is the guide extension catheter invaginates the balloon, and you're in the place of interest. Here, a case example. You see, microcatheter is coming in. Might push on the guide extension catheter. Mild push is still there, and while deflating the balloon, the guide extension engaged. The second technique is the surfing technique. It's very easy. Put a small balloon that you have on your table, inflate it half in, half out of the guide extension catheter, and push the bundle forward, and you will surf through the artery, as seen here.
How much you inflate?
2 to 4 atmospheres constant. It doesn't really matter if it's a small balloon, you can go higher. It's a big balloon and just do a bit of a inflation and push the bundle forward.
Just for prevention of dissection and
yeah, I will show you what's happening if you don't do it. In fact, you want to co-align the guide extension catheter to the vessel to be within the right way and don't disturb the wall.
But it should be a smaller balloon than the vessel diameter.
In the best way, it should be a smaller balloon. But if you have to save money and you have a 3.5 balloon on your table, then just go to 1 or 1.5-ish atmospheres and try to do it.
Okay.
The most important thing is that you have something which is leading your tip.
And is it bottle?
Doesn't matter. So, and now, actually I was doing a talk, I think 5 years ago, about guide extension catheters, and I was saying there is no innovation going on there. And we will be stuck. But the express one is a changer, and I love it. Why? You have this tapered, very distal bit, but that's not the thing. You see here a case that I actually did, I think, 2 or 3 weeks ago. A colleague did a stenting from the left main to the LAD. This was a very uncomfortable situation. The patient was really unstable, and we had to work really quickly. The engagement of everything was a pain, as you can suggest here. I then threw I think it was a 3.0 balloon just into the left main, and I tried to engage on the right-hand side here. You can see the guide extension catheter. Eventually, I was in the place to be, in the circumflex, and now I think the groundbreaking thing is you can work in a position like this without having ischemic troubles. And why is that? You see here the pressure curve. is still there. Patient's not unstable, you don't have hypotension, you can work your way through, do plaque modification properly, and this is because you have 4 side holes which are actually contributing, providing antegrade flow to the distal vessel. So,
Put the guide for the stent.
what's sorry?
Guide extension through the stent.
Yes. That was the thing which makes it a bit, made it a bit, it was a bit of trouble thing to go through. As you can see here, I had some resistance. It's probably a mixture of this anchor technique and surfing technique. As you can see here, now I pushed on the guide extension catheter, now it jumped in. Balloon was getting engaged deeply to the distal bit of the circumflex, and then the whole bundle jumped in. I want to show you last, and then I give over to you. Sorry for the delay. I don't, because if these guys are not co-aligned, then you will end up in a catastrophic situation. I'm showing you a patient which was done by a colleague in our hospital. Yes, you see a tortuous circumflex. It's not looking really complicated, but as always, circumflexes are not easy to treat. He was not able to deliver proper equipment to the distal vessel. He actually then put a stent, or wanted to put a stent in, was not able to engage it or deliver it. And then he did something you should probably not do. At least I learned the lesson out of it. He injected forcefully through the guide extension. And what actually happens, and I'll have to show it to you because hopefully at least someone will remember this talk, this picture. This patient actually died a year later, had a huge infarction after this. You should not do forced injection while the guide extension is not co-aligned to the vessel. It'll actually end up like a water pipe. You blew up the whole vessel, the vessel wall. But this is not the way how we should use them. So, the take-home messages are: do not do forced injections. Use your guide extension properly. Do it with a technique which you like. Call it however you like. It does not matter. The expressman is providing some blood flow to distal vessel, allowing complex PCI in a comfortable situation, actually. And thank you very much for your attention.